Firstly, a couple of grants that used to appear in there, which is the Improved Better Care Fund and the Adult Social Care Discharge Fund, have been aggregated. So that now appears as Adult Social Care Better Care Fund grant. It is not new money, but on the plus side, it hasn't reduced either. It is literally just those amounts aggregated. This falls in line with some changes to the national part of the Better Care Fund requirements. So to ensure that it's still meeting the objectives of that those two were there for. So objective 1 is requirement to reform to support the shift from sickness to prevention. And objective 2, to reform to support people living independently and a shift from hospital to home. So the ethos of what they required from those two grants are still there. They're laid out in there. So what we have had the opportunity to do through this year's Better Care Fund submission is items that have previously appeared that don't fit those criteria and are solely funded either by the local authority additional contribution or the ICB additional contribution have been removed. So there isn't less Better Care Fund money. And if the numbers look like that, it isn't. There are schemes that didn't fit those that are solely provided by the local authority or by the ICB. And we have removed those because otherwise we have to do onerous reporting on something that doesn't actually fit what we're going to have to report on. Those were just the key points I wanted to bring to everybody's attention.
Thanks, Pete. We've had a proposal for opening comments. Can I have a second of that? Thanks, Deb. That's Councillor Andrewson. Any comments or questions, Debbie?
I just have one point of clarification. Presumably, this is now for 1 year, because I think previously we had it for 2-year period, but it's gone back to being just for 1 year because, as you've said, it is quite considerable officer time, both from the ICB and from us in reporting. So it is now for 1 year again.
Absolutely, I can confirm that. Yeah, you're quite right. It always used to be a yearly, and then for 23 to 25, it became a 2-year plan. We did find that helpful, actually, because that meant the planning process wasn't repeated. This year, the documentation to do the planning work for the Better Care Fund was significantly late. It wasn't even properly resolved till end of February, and the figures kept changing in that. So we've had a bit of a pickle trying to put this together. We don't know what the Better Care Fund is going to look like following this year, is the upshot on that. So that's why they've removed it back to 1 year. We will still be required to do quarterly reporting, and that will still come to this board for noting and agreeing.
Thanks, Pete. Any further comments, questions? Okay. There are none. Michelle's fine. Yeah, thanks, Michelle. Therefore, it's been proposed, seconded. Those in favour of this recommendation, please show. Those, thank you. Those against? Those abstaining? Got that. Thank you, colleagues. And so we'll move on to the Joint Strategic Needs Assessment, JSNA. Received an update from you, Simon, I think.
Yeah, thank you, Leader. So this paper outlines is in 2 parts. So it's one about the JSNA and actually the data within it and the updates we've done most recently, and then assurance of this board, because this board has oversight through the Director of Public Health for the JSNA. So just wanted to highlight in section kind of 4, 5, 6 and 7 is the work programme. Really commend the board members to really look at, for example, the health of working age population. We know that our population is aging. I don't know if Michelle and I are at the same meeting this afternoon around frailty, but actually, if we don't start earlier, you know, people are going to get frail. So how do we really think about that working age population? We may want to think about it ourselves, but we're in that space. A few other reports there. For assurance in terms of transition, the JSNA will remain accessible after the 31st of August. Currently, as it says, we have a unique landing page for the Isle of Wight, and then it goes into joint repository. So that will continue, and we are developing a separate repository for the Isle of Wight in the next few months, and then we will work with the new Director of Public Health going forward, and they can decide how to do that with their own team. And we are appointing a suitably qualified team to be able to deliver the JSNA. But I'm confident that it will be a good product that we will be able to, as we separate from Hampshire, we move forward in that way.
Thank you, that's helpful. Any comments? Debbie?
Yes, just following on from what you mentioned, Simon, I do think that possibly there is room for the JSNA to be a little bit more visible on the website in terms of the landing page. The other thing I'd like to say is that currently the LGA are running a conference on health inequalities, and I have found the JSNA very useful because there are very wide determinants of health inequalities, and you can actually drill down on the JSNA to actually get some very useful granular data that actually can help to shape our strategies moving forward. Thank you.
There's certainly a lot of information there, and I'm not sure it's something we maybe look at that landing page. I know when you start to dig down, the amount of information is quite impressive. I know we had a presentation. I can't remember who came to it, whether it was the board or councillors. I don't remember, but it was both, yeah. And the information is extensive and impressive, frankly. And I'm comforted by the fact that we will, if I heard correctly, will remain with Isle of Wight data. Yeah. Ashley, I'll come to you after.
Thank you, Chair. Thank you to the Director of Public Health for referencing the needs of our population around frailty. I was just thinking about when we're going to be next updating the data. I appreciate you might not be involved, but I just wondered if you had any views about for children and young people. We know particularly around those children and young people who have special education needs and disabilities, their needs are actually changing very, very rapidly, whether they be needs around, for example, neurodiversity, or indeed needs around emotional wellbeing and mental health. And I'm thinking particularly around the work we're doing on the transformation improvement around special educational needs across the whole island, working very closely with our colleagues in the Integrated Care Board. And the JSNA is actually such a key document when we're making those commissioning decisions about what services we need. So I'm thinking about, for example, the very significant increase in the numbers of children who require speech and language therapy, occupational therapy, support around emotional wellbeing and mental health. I was in a meeting yesterday. It was actually the SEND Partnership Board when the Chief Executive of the Youth Trust was talking about the very significant increase in emotional wellbeing, mental health needs of primary school age children, and actually how they've got a very significant waiting list for primary school children. So I'm wondering about, particularly under the new arrangements with regard to public health, when we're looking to next update the JSNA, because I do think it's a key document to help inform our commissioning decisions.
Can I come back on both the points? So the first one is, and look to Wendy, I wonder if we can just do something on the front page about data, and I'll talk to Deb Downer, because that might be a way just to really bring it up to the front page of the website. So let's look at that. So what we're going to do, and I didn't talk through, we are updating all the data that is available before the partnership ends. So it will be there. If it's updatable, it will be updated. And then obviously after September, that person will do that. I think we've got to also remember it is about the health of the population. It won't have all the data that you have and how we just do that, but it will all be in there. And I think the children's bit sits in the healthy people chapter, but I will check and come back to you.
Thanks, Simon. Wendy would like to speak.
It was just picking up on that last point, because I think there's what we need to understand is the JSNA, as Simon says, it talks about that overview, population outcomes. When we're dealing with particular cohorts, we need to supplement it with more locally available data that we can quality assure as well. So I think it's not a thing that is static. It will be updated as and when data nationally becomes available in any case, and then we locally also need to look at what additional we can add to that when we're using it to add value. And I think the other point for me is around how we all collectively use it better, because I still think there's a little bit of people don't use it, and we find data analysis that's happening in other organisations linked to the island, you know, dealing with the island, who are almost duplicating and replicating some issues. So I think there's some work that we can do around making sure that for the island, for the partners around this table, the JSNA is the source which we then add to as needed.
Phil, do you mind if I carry on that conversation? So,
Yeah,
so I know that the ICB is merging its population health team with its analytics, and I think what they may forget is that we do a lot in the local authorities. So if you could feed that back in your route, that would be really helpful as well.
And it might help you with some savings.
Thanks, Simon. Yeah, I guess maybe if I heard that also from Wendy and from Simon, is it about, are you suggesting that there are other data that we don't actually have as much as updating the data we do have? I thought I heard that somewhere, actually.
So I think we need to make sure, so I absolutely agree with what Wendy said. You know, the JSNA is one of a number of data sources, but I think the fuller it is and the more up to date it is, the better. Because if we can have it as, I mean, the reality is that there's a number of different organisations involved in these decisions. And the more we can use it, I think, as a one-stop shop to reference the needs of our population. I'm obviously specifically talking about children and young people, the better. And we're always going to have, yeah, other data sets as well, but I think we should try and make it as full as possible.
We did a session with Laura's senior team. Why can't we do? Could we do the same with your senior team on the JSNA and have a conversation?
Makes a point well made, Ashley. And, no. Any other questions, comments on the JSNA? I mean, when after the presentation we had, I mean, I know some of the cabinet members spent quite a bit of time looking through it. It's fascinating the amount of data that's there to correct often what some of our colleagues freely expound in some of our committee meetings as being factual. It's very much a one-stop shop for proving that they're just talking out the top of their heads often. Actually,
I agree. It's a fascinating document. And actually, when I was looking at it the other day, because we were looking at it as part of the workforce board that Laura chairs, we were talking with colleagues about the needs of the population. And there's an amazing amount of historical information as well. And I thought, well, actually, we should share this with school geography and history teachers, because it's an amazing insight into the island and how it's developed over decades. It's absolutely fascinating, I thought.
Thanks, Ashley. It's always very sensible. Therefore, it's a report and an update, so no further comments, questions. Thank you for that, Simon, as always. Are you okay with that, Michelle? Yeah, good. Scott's going to give us an update from the Healthcare Partnership.
Thanks so much, Chair. The update around the Health and Care Partnership is that over the past 2 months, we have had a series of seminar meetings with partners around the room. The idea was to go back and visit the Health and Care Plan that was drafted in 2022 and was set as a plan for 2022 up to 2025. There was a feeling amongst partners that it may need quite a big refresh and that it may not be suitable anymore for 2025 because the landscape may have changed quite significantly. So we undertook a piece of work to revisit the full Health and Care Plan, the domains around it, as well as the 10 impact statements. We overlaid that with all of the various strategies that are in existence on the island from all of the partners in the wider partnership, as well as all the transformational programs that each of the partners have on their agenda for 2025. And the outcome was that we believe the health and care plan only needs a minor refresh. As an example, 10 of the impact statements that we'd listed in 2022 are still valid and still what our population requires. The only one, and sorry, 9 out of the 10, the one that we felt wasn't applicable anymore was related to a certain element of how we deal with COVID and the pandemic at the stage. There's a joint piece of work currently being undertaken to refresh the health and care plan. So we have the strategy team at the Isle of Wight Trust working alongside Donna in our team and Kathy Budden at the Trust as well. The aim is to align the 9 impact statements in the existing healthcare plan to a clear set of metrics. We're trying to pinpoint exactly what it is that, or what is the outcome. Maybe I know a lot of people don't like the word metrics, but we are now doing a piece of work to map our 10 impact statements to what the actual outcomes will look like, how they tie into all of the transformation and the strategies. And that'll then be wrapped up with a piece on governance refresh. So currently we have a multitude of regular partnership forums that are accountable for oversight of the delivery of the health and care plan. So one being the system delivery unit, the other being our executive delivery group. We have mechanisms such as the health and care partnership. So once we have realigned our strategies to our health and care partnership, we will also refresh the governance around which of those outcomes we're going to track through which of the governance forums. I don't know if you'd like to add anything, Michelle.
Thanks, Scott. So the only thing to add is just to provide some assurance to board members that over the next sort of 6 to 8 weeks, we will be completing some engagement stakeholder interviews just to kind of get people's views around those impact statements. And of course, we're doing an overview of the existing pieces of work. So as Scott said, I think we're fairly comfortable that we are tackling the right things, but it's just making sure we've got them all aligned. And just picking up the point around children's services that was made earlier, it looks like from the Health Watch data that we've got, one of the 10 impact statements will be focused on children, but we just need to make sure that we have those stakeholder interviews to confirm that's absolutely the right thing for us to focus on, because previously when we did it, the focus was very much on our older population.
Thanks, that'll come to Ashley. Wendy and then Ashley.
I think I'm going to add, because I think what we need to do is put in the link to this board, because it is this board that sets the overarching strategy, which leads what we then do in the other partnerships. So I think we did agree that we would bring a report to each health and wellbeing board that demonstrated and could give assurance to this board that the health and care elements of the health and wellbeing strategy were being delivered by the partners who sat on the health and care partnership. And I think that's where we make the link between the health and care partnership and this board. And so I think there's still a little bit of work that we need to pick up to make sure that the strategy that this board is in place to oversee being delivered is reflected in that work and identified in that work that we're doing through the health and care partnership.
Thanks, Wendy. Ashley. Yeah, I'll come back to you.
Great news about children and young people being the focus of one of the impact statements. That I obviously really welcome that. Very pleased to be involved in it, and specifically around health inequalities relating to children who have special education needs and disabilities, but also who are care experienced. And in terms of the development of the data dashboard, we're also developing a data dashboard for the Special Education Needs and Disabilities Partnership Board, which I co-chair with Anthony Harper. And so it probably makes sense to pick some of the same metrics to avoid duplication and additional work to collect, etc.
Ashley.
So Wendy, I absolutely agree. And I think when Simon and I wrote the original health and care plan, we were absolutely trying to make sure that we were making sure the Health and Wellbeing Board was what we were kind of reporting to and taking consideration of that strategy. So absolutely take that on board.
I think there's something else we could add to that. I was just thinking about that, Michelle. So there's something about bringing the kind of reports here, but actually then supporting challenging other boards. So what can the Community Safety Partnership do if that's an issue, or thinking of the Health Protection Board with the immunisations? Actually, if we're finding there's an issue, how do we then use this board to disseminate back out to other boards with a clear ask?
Thank you. Any further comments, questions for Scott? No? Okay. Michelle, you okay with that? Good. Let's have a look at our work plan. Any comments? That's page 85, 86. There's further population I've noticed of the plan. But any comments on that? Emma.
Thank you. Only the bleeding obvious one that November looks extremely busy. So if we want to deep dive into particularly one of those safeguarding reports in our day jobs, we'll have read them anyway. So I've just wondered whether the board thought it might be an idea to split them across 2 meetings, focus on adults for one and children on another.
Thank you.
This board's role in safeguarding is interesting, and it is really to note because they go to the safeguarding partnerships, which most of us sit around. So it's just kind of, you're right. It's what do we do differently here?
And I think we've mentioned digital inclusion exclusion should come forward at some point into that work plan.
Just picking up the point that we just made around the health and care plan, I'm just wondering around the frequency of bringing back the progress against that health and care plan. So accepting the fact that it will probably take us a couple of months to get kind of that refresh in play, but I would imagine this board will want to understand the progress around it, and picking up Simon's point around how do we use this then as the kind of pivotal point.
So what would you suggest, 3 months or 6 months from the July?
So I would say this board would probably want to have it either every other board or every sort of like 3 months.
Yeah. Okay. Well, please. Wendy.
Sorry, I think there's something around the frequency at which this board sits. It's not a hugely frequent board, so my advice would be that we have it as a standing agenda item on each board. And the degree of detail to which comes forward is either an update or no further progress since. But I think it's important to have it as a standing item.
Views on that?
Yeah, I agree.
Any other views?
I would agree with that as well.
Well, we'll take that as read. We'll put it as a standing item on the agenda. Thank you. Any further comments? No further comments. That leads us to just members' question time. Any members' question? You all,
I'd like to go back to something that's in the Better Care Fund report, and it's the amalgamation of services with the ICB and adult social care, I believe, and it's to do with occupational therapy and reablement. Tell me if I've got this wrong, I'm sure you will. But amalgamation means that there's a change of service somewhere, and has how are you going to measure the outcomes of the new outreach service of reablement, because this is what it's pointing down to, and utilising in my electoral division, the Adelaide, using that as a reablement as opposed to a day centre, and assisting the process within the East White. You're doing it over in freshwater as well, I believe. Reablement from there as well. Just wondering how this is impacting on what we used to supply in those centres, and where you think we're going to go with this, and how we're going to record the outcomes in future, Chair. Because it's all right to put these things in place. What impact are they having?
Okay.
What are we looking at for the outcomes?
I think the bit that you're talking about amalgamation isn't OT and reablement. So when we had multiple funding streams, we had the mandatory contribution to adult social care from the ICB. We had mandatory contribution from the local authority. There was also the Improved Better Care Fund, and there was the latter additional adult social care discharge fund. Now, what they all did, because we had to report against those separately, they all funded bits of a service that were the same one essentially. So we had services called OTIT, Onward Care and Independence Team. That was actually attached to our outreach and reablement team. It was a part of that, but it was additional funding that we could use to grow that team slightly, but we had to report on it separately because it was a different funding stream. Because the funding streams have now been merged, so the Improved Better Care Fund and the Adult Social Care Discharge Fund are now the Adult Social Care Better Care Fund in one place. What we've been able to do is remove those different funding streams, and every one of those we had to report on separately, and that's what's been amalgamated. So what we've done is refined the way the funding streams. We haven't fundamentally changed the services at all. What we've done is refined the way that we have to report on those. So for the Goldings and Adelaide, they used to be reported in the Better Care Fund separately. They've now been amalgamated. So it is now reablement service bed-based. So that is Goldings and Adelaide together. We haven't reduced the funding for them. We haven't changed the funding for those. In fact, there's been a slight increase because of we've had to do the inflationary uplifts for staffing, etc. We're not fundamentally changing any of those services. What we have done is taken services out that don't fit the criteria that was set out in the new Better Care Fund guidance. So things like Westminster House used to sit in the Better Care Fund template, and we used to have to report on that. We won't be able to report on Westminster House in the way it operates to support any of the things about discharge, etc., that the government wants us to report on. That was always added in as an additional contribution from adult social care. So it wasn't mandated. It's not something we had to report on because it was mandated through the ICB, etc. So what we've taken the opportunity to do is remove that line. What that doesn't mean to say is we've closed Westminster or it's not operating as it always did. It just means through the Better Care Fund reporting for Department of Health and Social Care, we wouldn't be able to evidence how it's meeting those targets. So nothing has fundamentally changed. We have amalgamated some of the funding streams because we've been given that opportunity to do so. One of the other bits that was in there about for the recommendation was to allow us then to work up the Section 75 amendment, which is our operating model. And under that, we put service specifications on, turn it away. So I'm looking at Donna because when I say we, Donna does a lot of this work. So we put together service specifications for each of those services, and each of those will have KPIs. We do that each time. So we will still be monitoring against how those services work. I don't know if that's helped in that space.
Extremely so. It's not the when I read something in here, that's certainly not reading the information that you've just given me. It's reading something that is taking me away slightly off course with this. I thank you for that. But what I would say is that can I just come back on the Westminster House situation, that you're not going to provide outcomes on that? Is that correct?
We are, but we're just not doing it through the Better Care Fund reporting to Department of Health and Social Care. So we still report internally on all of our services. That we still do, but we have to fulfill some templates which are monthly. Some of them were fortnightly, weren't they, to Department of Health and Social Care about how the Better Care Fund is spent and the outcomes it's doing. So we will still be monitoring the outcomes of every service that we provide. We just won't be sending it in that template to Department of Health and Social Care.
Could I just ask where the reporting line is for the operating plan and the KPIs? Is that an internal reporting? So, for example, you referenced that the if it was to be that you would set sort of like key objectives, metrics, where does that reporting go? So I was thinking more sort of occupancy as an example. So if you've got your service spec that's set, where will you report the progress against that?
That's done monthly on the templates against the targets that we've already set, because as part of the Better Care Fund setting process, they've asked us to set the targets that we think we're going to achieve. So we do that on a monthly basis. The quarterly report that comes to this board is an amalgamation of those reports. So every quarter you get to see, it's always a quarter behind, unfortunately, just the way it's done, but every quarter you get to see the amalgamation of those monthly reports that are returned to Department of Health and Social Care.
Thank you. So setting targets, I'm going to prolong this, but setting targets sounds an interesting thing for reablement to me. So how's that done from historical information? How do we do? I mean, people fall over and go into hospital and come out and need reabling, don't they? Either at home or in a care home. I just wondered where the targets came from. That's all. That you measure whether, yeah.
But so before Pete comes back on this, I think you've actually hit the nail on the head with my problem with metrics versus outcomes. For me, metrics just count things, and they don't actually give you a lot of information about the difference you're making to someone or the outcome an intervention has made to someone. So I'm assuming that a lot of those metrics we collect are defined by NHSE, DHSC, whichever body is going to exist in the future, and we therefore have to respond on the template. But I think the bit for us internally for our services is, regardless of counting those things, what is the difference that the service is delivering?
That's absolutely. So I'll just come back in on that and answer that question. It's absolutely spot on. So the Department of Health template that we do the returns on is pretty much interventions. How many people have reablement taken through? What it's not asking us is, which is another ASCOF measure, is how many those people are still at home 91 days after they've had that intervention. That in itself is not a good measure either, to be quite honest, because it doesn't tell you whether they still needed the full support that they went out with or they've become fully independent. So I'm just going to pick up on the reablement piece because I'm quite passionate about that. Back in the past, there used to be a national report, the National Audit of Intermediate Care Services, which very much looked at reablement and rehab in a very different way. And it was about outcomes. It was about measuring how many people would improve through that journey. Great for working with commissioners who perhaps didn't understand and looking at unit cost and why does reablement cost more than regular domiciliary? Because the National Audit Intermediate Care Services looked at cost per intervention and then the outcome of any reduced ongoing. So it was a much better way of measuring it. Unfortunately, through COVID, I think that's fallen by the wayside, which is a real shame. But I mean, it's nothing to stop us internally still doing that. We're not required to, and any measuring we're not required to makes it very, very difficult. I mean, we do collect stats to some extent that would evidence that, but there's nothing to benchmark it against anymore, which was always the key thing, because we actually did very well against national averages on that. Sorry, I just wanted to pick up on the reablement piece in general, since that was mentioned.
And so I think Wendy has actually asked the question that I was intending to ask. So for me, there are the KPIs, but actually for the work that we're doing around the health and care plan, those quality outcome aspects, where do we report those? But I think you've possibly answered that question in the fact that I don't think we necessarily have a benchmarking around that. But is there still a mechanism that we have to say that the services that we provide the quality outcomes that we would be expecting of those services?
There are for the internal things like reablement, whether it's bed-based or whether it's domiciliary-based, because we do still collect all of that information. We need to evidence that we're getting value for money out of our services and efficiency. So some of that is around length of stays and people's outcomes beyond that. For the more directly commissioned services, that is a piece of work I'm undertaking at the moment with our providers across the board, which is moving away from what is almost a traditional contract monitoring style process around quality assurance to outcomes, which is having a very different conversation with providers and acting in a very different way. So we can get them to send in their self-assessments that they've got all the right certificates for their electric, gas and all that. They've got it anyway. Their insurance probably wouldn't take them. Why are we wasting time on that? Why are we not working with them to evidence great outcomes for the individuals? Some of them have got it and we're just not very good at teasing it out. So it is a piece of work that we're starting to do now.
That's an interesting diversion at the end of the meeting. Any further comments or questions? There are none. It's 10:22. I will close the meeting. Take the rest of the day off and see you first thing tomorrow morning.